Hello everybody. Today we are going over the stroke protocol. Before we begin, I just want to iterate that these are time-sensitive patients. I know we all know that, and we want to try and keep our scene times down to 10 minutes or less. If for whatever reason we cannot limit our scene time to 10 minutes, just make sure you guys are narrating the reason why in the narrative. And with that in mind, if we think or know that we're going in for a stroke patient, it may be a good idea to ensure that you have extra hands available to help extricate that patient. We never know what situation we're going to walk into. We may need a stair chair, or we just may have all these other logistical concerns that really make it difficult to keep that scene time down. And if we just had an extra set of hands, we can get it done. So the first thing we're going to cover is the initial medical care for our stroke patients. As always, we want to determine a history of the present illness as well as their past medical history and initiate a stroke assessment as soon as possible. We are going to be doing the BFAST stroke screens. We're going to need to determine the patient's baseline status, whether it's their mental status or their body status. Do they normally have one-sided weakness or facial droop from a pre-existing stroke? Do they have dementia? Are they going to have problems following our questionings or our commands that would make us think, hey, are they having a stroke or is this normal for them? We're going to support their ABCs. We're going to want to give them oxygen if their SpO2 is less than 94%. However, we don't want to over-oxygenate our patients. For any stroke patient, hypoxia is a critical thing. We do not want it to get low. So if you think about a stroke, it's basically ischemia of the brain tissue. So if they have low circulating oxygen, that's not going to be good because they're already not getting enough oxygen to that area. But conversely, giving them too much oxygen can have detrimental effects as well. Hyperoxia is the condition of having too high of oxygen in the bloodstream, and that actually causes vasoconstriction, and that's going to be detrimental in our classic stroke patient. We're going to assess the need for drug-assisted intubation if we can't ventilate them otherwise, and we're going to monitor with an EKG and acquire a 12 lead if possible. Now notice it says if possible. Do not delay scene time for any of these things. We're going to get going and do everything en route. Another thing to consider are our seizure and vomiting precautions. The unique thing about strokes is we do not know where that stroke is occurring. So depending on its location, we can have a plethora of symptoms. If we go back to our Cincinnati stroke scale, which we don't do anymore, those symptoms were the common signs that we would have for the most common location for a stroke. But if a patient was having a stroke in the back part of their brain, a hindbrain stroke, they're not going to be presenting with those types of symptoms. So we never really know what type of symptoms our patient's having. They could be having a stroke and we can totally miss it. So that's why the BFAST stroke scale is a little bit more inclusive of the different locations. But keeping that in mind, we also can have a hemorrhagic stroke, so we can be running into a ICP scenario, and we would definitely have to be worried about vomiting precautions there. We're going to maintain their head and neck in neutral alignment, and it says not to use pillows. We want to elevate their head about 10 to 15 degrees if their systolic blood pressure is greater than 100. Again, remember, we could have an increased cranial pressure scenario here with a hemorrhagic stroke. We're going to be doing an IV en route unless they have low blood sugar, and then saying to give an 18 gauge AC. If I can't get an IV to give sugar, I'm just going to give them glucagon to get their sugar up. I'm not going to delay care if I definitely think they're having a stroke to do an IV. However, we have to keep in mind maybe they aren't having a stroke, maybe they're just hypoglycemic. So we definitely need to treat that right away as well. And we do not want to give them excess amount of fluid, especially for an ICP scenario. We do not want to overload them with fluid to make that swelling even worse. We want to assess our vital signs frequently and after each intervention. We need to anticipate hypertension and bradycardia due to increased intracranial pressure. We do not want to treat hypertension or give atropine for bradycardia if the systolic blood pressure is greater than 90. So if they have a elevated or widening pulse pressure, that's going to lead to a low heart rate. Remember Cushing's triad. So we have widening pulse pressure, bradycardia, and Cheyne-Stokes respirations, the irregular respirations. We do not want to treat that bradycardia with atropine. And then we're going to provide comfort and reassurance, especially if our patient is aware but they're having difficulties, expressing themselves. They can be very concerned, very worried. So we want to try and establish a means of communicating with aphasic patients if they're aphasic. So they might not be able to answer appropriately. They know they're not saying the right words. They know what they want to say, but we can express to them that we understand they're having difficulty, and we can try communicating just with yeses and nos by them squeezing our hand once for yes, two for no. And something as simple as that can help ease their anxiety tremendously. And we're going to limit their activity. We're not going to want them to be walking around. And we want to make sure that we get our patient in the cot, we secure them, and we get them in the back of the ambulance. I've personally been on potential stroke calls, and the patients, they want to get their keys, they want to get their cell phone, their charger, they want to do all these things before they leave, but we want to limit that activity, which is why, again, it would be great to have an extra set of hands here to help us mitigate all those logistical concerns, that we may need or the patient, may need done. And finally, for the IMC considerations, if we do have generalized tonic-clonic seizures, we're going to treat it per that protocol. We're going to give them Versed. If they have altered mental status, seizure activity, or neurological deficits, we definitely need to be checking blood glucose and treating per that protocol. And as I mentioned before, again, minimize scene time to less than 10 minutes, and we're going to be transporting to the nearest primary stroke center. So that is always going to be Woodstock. We're going to call a stroke alert as soon as we diagnose the fact that we're potentially having a stroke, so they can get that CT ready for our patient upon our arrival. So depending on the type of stroke that our patient is having is going to determine the characteristics of that stroke and the signs and symptoms that they are presenting with. The first stroke we're going to talk about is a thrombotic stroke. And these strokes are caused by a thrombus or a blood clot that develops in the arteries supplying blood to the brain. This type of stroke is usually seen in older persons, and it's characteristic of people with high cholesterol and atherosclerosis, or a buildup of fat and lipids inside the walls of the blood vessels. It's also common in patients with diabetes. So think much like a patient that has a heart attack. If they have coronary artery disease, they have a buildup of lipids and in cholesterol in their arteries, and that's going to eventually lead to a heart attack. So that's why for a thrombotic stroke, we have prodromal warnings. Those are common for that. So a prodromal warning is basically anything that happens to indicate that the patient is going to have a stroke. So these could be certain signs and symptoms, or it could be like a transient ischemic attack, a mini stroke. That is considered a prodromal warning. So just like our heart attack patients where they have angina without necessarily having a heart attack, that's an indicator that they're at risk for having an actual heart attack. So as far as onset is concerned, it can really happen anytime. Sometimes it happens while they're sleeping, sometimes not. And the development is gradual. Again, typically these patients have a series of mini strokes before they have the big one. A quick reversal is possible with TPA. We just need to be within that time frame. The level of consciousness, the decrease in it is usually pretty mild. They're usually able to comprehend and follow commands and everything that's going on. They just have very specific signs. They might not be able to say certain things, they might not be able to do certain things, but they're typically fairly alert. A headache may be present, but it's not that severe. They may have high blood pressure, they may not. They're not going to have any nuchal rigidity, no stiffness in the neck, and vomiting is rare for these types of patients. The next type of stroke is an embolism or an embolic stroke. These are exactly the same thing as a thrombosis, except the clot forms elsewhere in the body, not in the brain. So these tend to be rapid in onset, very sudden, and they don't have any warning signs because, again, with the prodromal warnings in the thrombotic stroke, we have those TIAs. With an embolic stroke, a thrombus is forming elsewhere, and all of a sudden it's lodged in the brain, so bam, you have a sudden onset. It's rare that this occurs during sleep, but it is possible. A quick reversal, just like a thrombotic stroke, is possible so long as we are within those TPA timeframes. And all the other symptoms are pretty similar to a thrombotic stroke. The level of consciousness is going to be pretty normal, is slightly depressed. They may have a mild headache. Hypertension is possible. Nuchal rigidity and vomiting. Vomiting is rare, no nuchal rigidity. Next, we have our intracerebral hemorrhage, so we're going to have a bleed within the brain. This has no warning symptoms. The onset during sleep is rare, and the development could either be gradual or sudden. So we could have a aneurysm, and the patient just has a rapid rise in their ICP, and they have a hemorrhagic stroke. Again, this could also be gradual. We could have a patient that has a slow bleed and that ICP is rising very slowly. Our at-risk population for this are our elderly because they tend to have shrinkage of the brain as we grow older. The patients on blood thinners because they could have a slow bleed that just won't clot. It's just going to bleed very slowly. And also our alcoholics, our severe alcoholics, because they also have a shrinking of the brain. So they are more at risk for the gradual onset where other people may have more of a sudden onset. There is no quick reversal for this. We can't give these people TPA. In fact, that would be contraindicated. And again, these patients are going to go to a primary stroke center. We may suspect that they are having a hemorrhagic stroke, but we want to get them to the closest CT possible because they're going to be flying these patients out if they feel like they can be managed. The decreased level of consciousness is going to be severe. The hemorrhagic strokes that I've had, these patients were out. They were out, and we could not rouse them, and they just got a brain bleed going on. Headache, if they are alert, it's going to be severe. Again, we have that ICP. They may not have hypertension. So again, we're talking about increased ICP, so we would expect a widening pulse pressure. But they might not have high blood pressure. They may have nuchal rigidity depending on where that ICP is, and vomiting is definitely a probability here. And finally, we have the subarachnoid hemorrhage. This is usually caused by a aneurysm or a head injury. Again, the intracerebral hemorrhage, I don't think I said it, but that could be caused by an aneurysm or a head injury as well. The subarachnoid hemorrhage, it's going to be rare that it has any early warning signs. However, the signs and symptoms of this are going to be a severe headache. They can have an altered level of consciousness, coma, fainting, seizures. They're definitely going to possibly have a stiff neck and weakness on one side of the body. But the main thing here is the patient is going to have a sudden severe headache. Onset during sleep is going to be rare. Development is rapid. Quick reversal is possible if they get the treatment right away. This is not anything that they can be doing at a primary care center, however. They may have a decreased level of consciousness, and hypertension is common for this as well. For brainstem or posterior strokes, we have the 5 Ds. We have dizziness, we have diplopia, which is going to be double vision. A good way to assess for this is have them track your finger. If they're telling you they see double, look at their eyes. Are their eyes tracking your finger, or at some point does one of their eyes stop moving? If that one eye stops moving, then naturally you are going to see 2 images for one object. So that could be a sign of a stroke. Dysarthria is is the difficulty in forming words, controlling the larynx. So this is going to be the patients that have difficulty speaking. And then we have dysphagia, which is going to be our patients that have difficulty chewing and swallowing. And finally, we have dystaxia, which is going to be incoordination. So if you think of ataxic gait, dystaxia is going to be just gross incoordination of our patients. So for these brainstem or posterior strokes, we're going to potentially have severe vertigo. For any of you guys that have worked with me, whenever there's a vertigo patient, I say, hey, this could potentially be a stroke and we should treat it as a stroke and call a stroke alert. The majority of the times, vertigo is not a stroke, but it can be, so it's important that we recognize that and take the necessary precautions. Nausea and vomiting are going to be common, and they may have difficulty breathing, especially if we're talking about the brainstem where we have our respiratory control centers. We're going to have visual field loss, gaze palsy, so that's that double vision that I talked about a little bit, and partial or complete loss of hearing. So hallmark signs of this are going to be cross-finding. So what that means in our cranial nerves, we're going to have the same sided type of deficit. So you see a left-sided droop, and then we're going to have contralateral or opposite side motor sensory deficits. So they may have droop on the left side but weakness on the right side. They're also going to have decreased pain and temperature sensation and possibly a loss of 2-point discrimination. This is not a test that we would really do in the field or that I have seen anyone do, but they will lose the ability to discern two distinct points, like on their finger, for example. They won't be able to tell that that's two separate objects. It'll feel like just one thing touching them. And just like when we're talking about heart attacks and we talk about STEMI mimics, we can't talk about strokes without stroke mimics. So there is a list of the common stroke mimics in our protocol. And the first one is psychogenic. And this is basically, looks like a stroke, but there's no objective findings in the exam. There's nothing to indicate that the patient is having a stroke. So they would label this as a psychogenic stroke. Then we have seizures. We all know that a postictal patient could potentially look like they are having a stroke. Hypoglycemia is another common one that can mimic a stroke, which is why it's always very important that we check our patient's blood sugar. Infection. If you think about an infection, Bell's palsy is a viral infection of one of the cranial nerves, and that can lead to paralysis on one side of the face. So a good assessment for here is to see if they can wrinkle their forehead on the affected side. A stroke patient might be able to do this, but a patient with Bell's palsy is not going to be able to wrinkle their forehead. Migraines with an aura. This could be similar to a stroke, especially if it's a sudden onset of headache and we got like these prodromal warnings. We might think, hey, this could be like a stroke, but it also could be a migraine. Hypertensive encephalopathy. So this is going to present with a headache, delirium, significant high blood pressure, cortical blindness, edema, and seizures. So we might think that we have a stroke situation going on here. Wernicke's encephalopathy. This is very common with chronic alcohol users. They're going to have ataxia, which we talked about, dystaxia being one of the signs for posterior stroke. They're also going to have extraocular motor paralysis, so they're not going to be able to move their eyes. They may all the way, so they may have double vision, and they may have confusion, altered mental status, so that can look a lot like a stroke. And then finally we have like a CNS abscess, or CNS tumor, so anything affecting the central nervous system can potentially present like a stroke. And lastly, we have drug toxicity. On page 2 of our protocol, we have a stroke alert checklist, which we could fill out if we feel so inclined. So this includes our BFAST assessment as well as other assessments, and a helpful past medical history and medications that we need to be aware of or concerned about for patients with a potential stroke, and if they are candidates for our typical TPA therapies. So initially we're going to look at the BFAST. This is going to be our go-to assessment that we're going to do on all of our stroke patients. Remember, we're no longer doing the Cincinnati. If you incorporate some of the Cincinnati things in addition to your BFAST, that's fine, but the BFAST should cover all those stroke assessments that we did in the past. So starting with B, it starts for balance. So is their coordination? Is it unsteady? Did they fall? A lot of times we go for these fall patients, we need to assess them for potential stroke, because why did they fall? Did they trip on a rug, or did they trip because they're having some medical issue going on? So other things we can assess for balance: if they're not dizzy, if they seem fine there, we can do the finger to the nose and alternate that rapidly. They have a little bit of difficulty with that. That can be an indication that they have a little bit of dystaxia going on. Another thing to do is the heel to shin test. So if our patient's standing up, can they put their heel on their shin? If they are having balance issues, that might be a little bit difficult to do. If they're sitting in a chair, are they kind of tilting to one side because they can't really support themselves? And do they have vertigo? So I'm sure you guys are thinking about, I never had a patient do heel to a shin test before, especially for a stroke. These patients were loading and going. However, if we encounter these patients that don't want to go to the hospital, these lift assists, and we want to really rule out a stroke, these are some of the things that we could ask them. Some of these more involved assessments, to help cover us and to ensure that we, are signing off a patient that is truly okay to not go to the hospital. Moving on to E, which stands for eyes, we're going to be assessing for vision changes. Do they have blurred vision? Blurred more than normal. I mean, some of these patients might have blurred vision all the time, so we're looking for changes in their normal status. So again, we talked about the diplopia, the double vision. They may lose some of their visual field. They may have photophobia, so sensitivity to light. We're going to be looking at their eye position as well. Do they have a fixed gaze or a gaze palsy? Or is one of the eyes, can't really move all the way to the left or to the right? So that's important that we do a good eye exam in the back of the ambulance or when we're doing our stroke assessment. Moving on from there, we have face. We're going to be looking at their smile. We're going to ask them to show their teeth. A lot of our older patients tend to be a little bit sensitive about this. They're a little apprehensive to show their teeth because they might be embarrassed. But tell them that, hey, we need to see your teeth when you smile, so we can truly assess that they have paralysis on one side or drooping on one side. Can ask them to close their eyelids and to wrinkle their forehead. And again, we're going to note any unilateral weakness or asymmetry. Moving on to arms, it's very important, this is the drift test, that the patient closes their eyes and holds their arms out. We want to hold this for 10 seconds. We may not need to hold it for 10 seconds because their arm might start drifting right away. Then we have speech. The common thing is you can't teach an old dog new tricks or sing happy birthday. I've never had a patient sing happy birthday, but I do ask them to repeat certain phrases for me to help me assess their slurring. I've had patients where slurring might be normal for them, so if there's family there, it's important that we ask these questions for any of these assessments to determine if this is new or if this is a normal thing for them. And finally, and we cannot talk about this enough, we need to know when their last known well time was. So they might say, yeah, it happened at 12. Well, that's when they saw them and that they noticed it. But when was the last time that they were definitively acting normal? I've been on calls before. I'm sure we've all been on calls where the patient, this started in the morning when I woke up, or when my husband woke up. Well, were they fine when they went to bed last night? Yeah, they were fine. So we don't know at what time during the night that this happened. If they woke up like this, it could have happened at any time. So it's very important that we document a last known well time, the last time the patient was at their normal baseline. Moving on to other assessments, we're going to be assessing their level of consciousness, their level of orientation, and their Glasgow Coma score. We want to make sure that they are responding to commands appropriately, that they don't have any gross hearing deficits, typically on one side, or sound sensitivity. We're going to ask them to say ah. We're going to be looking at their palate to ensure that it rises on both sides. We're going to be looking at their uvula to ensure that it's midline. Have them stick out their tongue and note if that remains midline. We're going to note any abnormalities. Neglect, this one I had to look up, but it's one-sided extinction is what the phrase, how they phrase it, which is visual, auditory, or sensory. Those are the things it tends to affect. But some examples of neglect would be like the patient forgetting to put like the neglected side, their arm in a sleeve, or if they don't shave one side of their face, or if they're eating their food and they don't eat food on one side of the plate. They may be bumping into walls on that side of the body, or if you're talking to them, they might not be looking at you if you're on that neglected side. And they may, if you're talking, if they hear something, they might not remember hearing it if it's on the affected side. So that's what to neglect is, which is interesting because I never really, noticed having patients like that. But now that I'm aware of it, it's something I'm going to be looking out for. Just like with the arm drift, we can assess the motor in their legs. If they're laying on the cot, we can have them raise their legs to see if they got good strength, if they can hold their leg up. Then we're also going to be looking for sensory deficits, and apparently sweating on one side would be another sign. Two or more of these may indicate large vessel occlusion, so definitely note these as you find them. Last but not least, we have past medical history and medications. There's a lot of information on this list for the past medical history. These are all the risk factors for a stroke. I'm not going to cover all of them, but some of the big ones are AFib, A-flutter. We all know that that can lead to stagnation of blood in the atria, which is going to form, blood clots, which can lead to an embolic stroke. Family history of strokes, previous strokes, peripheral vascular disease, previous TIAs, those mini strokes, any bleeding disorders or intracranial surgery or bleeds. Do they have a history of coronary artery disease, diabetes, hypertension? Are they heavy tobacco users? All these things are, medical histories that are pertinent to assessing a stroke patient. Moving on to their medications, we want to know if they took any anticoagulants within the last 48 hours. There's a whole list here. In addition to anticoagulants, we also have platelet inhibitors. Our classic one, and one that a lot of our patients take, is aspirin. So that may be a factor in the treatment that these patients receive. And finally, we also want to ask for illicit drug use like cocaine and other vasoconstrictor drugs such as amphetamines and PCP. So destination options, we only have access to primary stroke centers here. So whether you go to McHenry, Huntley, or Woodstock, they're all primary stroke centers. So being the fact that we are on Woodstock, it's important that we take our patients to the closest stroke center. You guys may run into some slack from the patients because not the patients, but their families, because they know that Woodstock doesn't do admissions and they want to go to a further facility. It's important that we communicate to them that taking them to Woodstock is really going to be the best treatment for the patient, so we can diagnose that stroke early and get that treatment on board so long as they are a candidate for it. And again, if we think that our patient is having a intracerebral stroke, hemorrhage, and that we know they're not going to be able to treat it at Woodstock, well, they're probably not going to be able to treat it at Huntley or McHenry either. If they're going to be treating a hemorrhagic stroke, they're going to be flying those patients out or transporting them via ground, depending on time of transport to a comprehensive stroke center where they can really handle those types of patients. So again, a couple things to hit home. Limit our scene time to 10 minutes or less. If you think it's a stroke, don't be scared to ask for help. Make sure we document our last known well time, the last time they were seen acting normal, and onset of symptoms, and get these patients on the road as soon as possible. Do all the care that you possibly can en route. Don't delay transport for any unnecessary care. All right, thank you guys. Have a good day. Talk to you later.